Coming up today, our patient this morning happens to be an RN here at the University of Kansas Health System. Her journey to better heart health is very personal. The medication helping her is incredibly popular, but only newly recommended to heart patients. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. This morning we're discussing a relatively new choice for treating heart patients, GLP-1 medications, and we will get to that shortly. But first we have today's morning rounds, and this one is for you if you love your coffee. Oh my gosh, you'd have to pry this from my Kung Fu grip. For years, patients with AFib or atrial fibrillation have been told to avoid coffee because of caffeine. But there is a new report published in JAMA, the Journal of the American Medical Association, saying coffee may actually help with AFib. Electrophysiologist Dr. Rhea Pimentel joins us to discuss this study. So this could help with AFib, doctor?
Absolutely.
So this concluded that this study says that 1 cup a day was associated with a less recurrence of AFib compared to people who avoided caffeine altogether. What do you think of it?
I actually think this study just confirms everything that we as electrophysiologists have sort of seen. There's this general thought that caffeine revs up your heart and makes you more susceptible to both atrial fibrillation as well as other ventricular arrhythmias like ventricular tachycardia. But if you actually look at some of the prospective and observational data, that's not the case. And this was sort of the first randomized trial. So they actually told patients, hey, you take caffeine every day and you don't take caffeine every day. That proved what we already knew, and that caffeine is protective.
That's incredible that caffeine would be protective, because it's rare that you hear that. And as someone who has slight anxiety, would it help me with my anxiety, or should I still lay off?
I don't know if it would help you with your anxiety, but right. I definitely think that if you have what I tell my patients is if you have AFib and you like coffee, you should by all means drink coffee. It's not something that's going to affect how much AFib you have.
What other things could trigger AFib?
Well, definitely we know there's been a lot of studies looking at alcohol use. So any amount of alcohol is going to increase your risk for developing atrial fibrillation, both kind of urgently, like if you had partied the night before, as well as long term. And then things like obstructive sleep apnea, being overweight, not exercising a lot, all of those things we look at when we see patients with AFib and start talking about lifestyle modifications.
Dr. Pimentel, thank you so much for joining us, and thanks for being such a supporter of this program and helping us educate all of our viewers. We really appreciate your time.
You're very welcome. Take care.
Have a great day.
Bye.
And now to today's topic on GLP-1 medications. You may know them by the brand names like Wegovy, Ozempic, or Mounjaro. That's what a GLP-1 medication is. Originally, they were used to treat diabetes and then weight loss. Ginger Ireland Hoffman is using them for her heart. It was inspired by a devastating personal loss.
This is the personification of everything. Like, he always made me laugh like that.
When Ginger Ireland Hoffman talks about her late husband, Chuck, her love for him and her grief over losing him are so close to the surface.
He is such a good person. He would do anything for anyone.
And when she looks back, she sees it was those initial years of the pandemic and the quarantine that really sparked the downward turn in his health.
With COVID, they came home to work. And he never went back to work, so he was always at home.
Chuck, who had struggled to lose weight before the lockdowns, became like countless people in the same boat during that surreal time. He continued putting on the pounds, and his health problems associated with the extra weight got worse. Chuck passed away in 2022.
Realizing that if I didn't lose the weight and get back on track to where I'd been, that I could very well be in the same position as my husband, and I wasn't going to do that.
About 10 months after her husband passed, Ginger made an appointment with the University of Kansas Health System OBGYN and weight loss specialist Dr. Joanna Finkel to ask about taking a GLP-1 weight loss drug.
I said, I don't know that I'm your ideal candidate. I don't know that this is the right thing for me, but can we meet?
It was not an easy fix, just filling a prescription. In addition to prescribing a GLP-1 medication, Ginger says Dr. Finkel helped her modify her daily workouts to include heavy weights. She also changed her diet, which included drastically increasing her protein intake. 2 years later, and 70 pounds lighter, Ginger says she feels fantastic, and her cardiologist, Dr. Ryan Farrell, has given her some great news.
My blood pressure has improved, my heart rate has improved. I'm taking the vacation, I'm going to get healthy, and I'm going to show my kids that this is how you live your life.
While there is nothing she can take to ease her grief, Ginger says time is helping, and every day forward, her memories of Chuck become just a little bit bigger than the sadness.
It's not forever. All the memories that you made before are forever, and those are the ones you have to hold close.
Aw, Ginger. Thank you for sharing that with us. And thank you for sharing Chuck with us.
Yeah.
What an amazing guy.
Yeah, he was really the most amazing human.
One of the best parts of interviewing you the day we came to your house was seeing all those pictures of him and hearing the stories about him and how terrific he was. I bet he would be so proud of you. So proud of you.
Probably laughing because he knows how uncomfortable this would be for me.
Okay, so right now he's looking down and he's kind of getting a kick out of this,
Oh, yeah.
that you're in the spotlight.
100%.
We're so glad you're here, and we are also so grateful that we have your cardiologist, Dr. Ryan Farrell, with us, and we also have another doctor on the set. We have obesity medicine specialist, Dr. Kathleen Beaver. Thank you for being here. Dr. Finkel couldn't join it today, but Dr. Beaver, you come highly recommended by multiple people, and be careful because now you're on the desk, so you will be asked back. Just say it's happened to Ginger now 4 times. So we'll see you and Dr. Farrell back. Ginger, how are you feeling physically today? I know that was a lot to start the morning off with.
It was a little bit. I feel great. I feel like life is 100% better because I can do more things and I can hang out with the kids and I can keep up with the kids. Mm-hmm. So those were my nieces and nephews in most of those photos, and they are 10 to 13. And we run. When they're at my house, we just go from 6 o'clock in the morning until probably right before midnight. Like,
right.
Let's go.
And now you can keep up. Before you were struggling to keep up.
Yeah, I was going to say, I mean, and less medications that you're on now. I mean, your weight, how active you are, the problems you used to suffer from. So, I mean, it's great to see you like this.
So, Dr. Farrell, what exactly are GLP-1s doing to help the heart specifically?
So, great question. They have multiple beneficial effects on the heart. And collectively, what that does is it reduces a patient or a person's cardiometabolic risk.
Okay.
And I think we have this on this slide here. Perfect. So, the main thing is that what most people know is that the weight reduction. So, in the clinical trials, you had both reduction in your weight along with your waist circumference. And then that also reduced your hemoglobin A1C. And what that is, that's a marker of your glycemic or sugar control over like a 3-month period.
Okay.
So that's going to reduce your risk for developing overt diabetes. And so by helping improve a patient or a person's weight, what that's going to do is lead to less risk factors like high blood pressure, hypertension, and then also like obstructive sleep apnea. And then you know, obesity is an independent risk factor for all-cause mortality.
Right.
So anything that can target obesity is going to be good for us.
And that's why we have Dr. Beaver on the show, obesity medicine weight loss specialist. Is that the correct? It's a long title. It's so important that we have such a great focus on this. Can you tell us a little bit about the research that you track and you follow supporting the uses for GLP-1?
Sure, of course. So these medications have been very exciting and the research has been so promising. And we love that we have another tool to really effectively treat obesity and by doing that lower the risk or improve other cardiometabolic comorbidities or other conditions associated with obesity. So the research today has collectively has shown that other than type 2 diabetes and obesity, that these medications have also been effective at improving obstructive sleep apnea, fatty liver disease, and chronic kidney disease, and heart disease. And there's several other studies currently happening looking at other metabolic conditions, and most of those are promising as well. So we're really excited that that these medications are really having a positive effect on metabolic disease. In terms of the heart, the studies have been looked at both in patients who have type 2 diabetes and patients who don't have type 2 diabetes. And essentially the findings are pretty similar. So when we think about someone like Ginger who does not have type 2 diabetes, there was a large study that was published a year ago this month called the SELECT trial that looked at about 17,000 patients. And they either put the patient on semaglutide, which is one of the injectable medications known as Wegovy or Ozempic.
Is semaglutide the same as GLP-1? Are those synonyms?
GLP-1 is a class of medications. So that a GLP-1 is a hormone that our body makes, and this class of medications mimics that hormone and sometimes another hormone as well.
Okay.
So semaglutide is one of the medications within that class. It is what we call a GLP-1 agonist.
Got it.
And so in this study, what they found is patients who had a history of a heart attack or stroke had a decreased risk of having a second heart attack or stroke on this medication by about 20%. So that's pretty impressive. And so that's exciting for us as what we would call a secondary prevention for patients with known cardiovascular disease. So these patients would have a lower risk of having a second heart attack or stroke or dying from a heart attack. So, and this is why it's now approved for secondary prevention of cardiovascular disease. And then the other studies of the heart disease in particular are improvement in heart failure symptoms. So patients with heart failure see improvement in their symptoms, decreased hospitalization, and it seems like that might be another really great place that we will be looking to use these medications.
It's fantastic how this has grown, and it's growing so quickly. This research has sparked big moves by the FDA. Earlier this year, the FDA approved one of the injectable GLP-1s to help treat people with cardiovascular disease. And then just last month, the FDA approved an oral GLP-1 to reduce cardiovascular risks. So Dr. Farrell, do you as a cardiologist often refer your patients to an obesity medicine specialist like Dr. Beaver, or does it go the other way around? How does that work?
So I think early on, being a novel medication, especially being injectable and for diabetes, I think cardiologists were a little hesitant. But I think as they started to gain traction, oftentimes, and gaining expertise, like in the weight reduction clinic, we'd make our referrals there. But now that we have the improved clinical outcome data, I think cardiologists are becoming more and more comfortable prescribing them. And in fact, what we do, we kind of have a fast track. We have a clinical pharmacist in our clinics that we can refer to, so that, getting the right diagnosis, to get it, to affordability and cost, and then titration of the medication, and then monitoring for, known potential side effects and how well the patient's tolerating it.
Do you, Dr. Beaver, do you work with cardiologists often in tandem, collaborate?
Yeah, we definitely share quite a few patients. So we often get patients over our clinic that their heart doctor sent them over because they told them that if they lost weight that it would be better for their heart.
Ginger, how long have you been taking the GLP-1 drug that you're on?
Since March of 2023.
March of 2023. And then how soon after you started taking that, March of 2023, did you begin to notice, I feel better?
That took a little while because, of course, you're not losing weight at a high rate of speed. Like, it's a very slow process, and it takes a lot of fine-tuning. I feel like the lifting weights was integral in this working the way it should, and being more active. So, going from 10 to 15,000 steps a day to 25 or 30,000 steps.
30,000 steps.
Yeah, it depends on the day. But yeah,
just a time out. How do you do 30,000 steps in a day? Because I'm really trying to get.
I work here.
That's right. So she's running around. That's right. That's right. You get a lot of steps during your job because, Ginger, you are a cardiothoracic surgical ICU nurse.
Yes.
So you're also working with heart patients.
Yes.
When we talk about, and we're going to dive into that in a little bit, there are so many layers to this. When we talk about all the lifestyle changes that Ginger made, one of them she mentioned was upping her protein. What does the upping the protein intake have to do with weight loss or making the GLP-1 work better?
Well, I think in general, we don't eat enough protein. And so we know that lean protein helps, potentially helps preserve our lean mass. So when we talk about our body weight, we're talking about fat mass and lean mass. And increasing protein intake helps provide the structure to allow our lean mass to stay, preserve it as we're losing weight, and even potentially build muscle when we're doing things like strength training. So we really encourage patients to increase their lean protein mass or protein intake, because in general I feel like we just historically don't do a great job of eating protein here in the United States.
How much protein are we supposed to be eating every day?
Well, that's a loaded question, and
I mean, I'm hearing some wild numbers on Instagram.
But I think it depends on what patients' goals are, and maybe even where they fit in the age spectrum. But in general, we typically recommend somewhere between, what we would say is 0.8 to 1 gram of protein per kilo to maintain weight, and if we want to lose weight, even pushing that up to 1.2 up to 1.5. And
like in pounds, how many grams of protein should we eat in pounds? And I know this is not for everyone. I'm just saying, generally speaking, what would you tell
Well,
someone?
it really does vary with what the patient weighs.
Okay.
Right, to start out with. So, so someone who has a normal weight, I think it's reasonable to aim for, 80 to 90 grams of protein if you're a healthy adult male.
Okay.
Can even go easily up to 100 to 120 grams of protein.
Is that the same for women?
Well, women tend to weigh a little bit less in general. So again, it just kind of depends on their weight.
Depends on that.
Yeah.
We're talking about these medications. Is there anyone who would not be a good candidate for a GLP-1, Dr. Farrell?
Well, that's a great question. I mean, I think probably the most important thing would be people that are pregnant or that plan to breastfeed. And then there are known contraindications, thyroid cancers, endocrine neoplasms, MEN2NA, and then of course hypersensitivity or someone that's allergic to it.
Allergic to the GLP-1?
Yeah.
And then of course pancreatitis, although that's kind of a moving target more recently.
Yeah, so the latest data on pancreatitis is that if these newer generation, kind of the 2.0 version of these medications, we don't see pancreatitis very often. So the risk is really less than 1%. Now, if a patient has chronic pancreatitis or recurrent pancreatitis, that would definitely give us pause to put them on the medication. Gastroparesis, that's pretty severe, would be another reason that maybe we wouldn't put someone on, because this medication, one of the ways it works is it slows how quickly you digest food.
Sure.
So if someone already has a condition that slows their stomach, and we add to that, we could make them feel pretty sick. The thyroid cancer is a very rare form of thyroid cancer that's actually hypothetical, because there have been no human cases associated with these medications. In the original, what we would call preclinical trials, which are the rodent studies, there was some question of whether or not these medications were associated with an increased risk of a very specific type of thyroid cancer, but in all of the human studies and everything post-market, we haven't seen that. So Dr. Farrell's absolutely correct. It sits on the label. We do talk to patients about it. We do screen for that cancer, and if we did stumble across someone who had that, we probably wouldn't start them on it. But we know that that is probably just a hypothetical risk.
And that's why it's so important. What I gather from everything you're saying is it's so important to have experts who are monitoring this, because it's not for everyone. Ginger, what is your, you mentioned increasing your protein, lifting more heavy weights. So what does the typical workout look like for you?
Typically it's rowing. Because I'm
okay.
working all the muscle groups when I do that. I was a big swimmer in high school and college, and that was just a part of my everyday life. Clearly, in the Midwest, it's not something you can do every day.
Right.
Unless you just have a pool in a building. And I live pretty rurally, so we don't have that. I'll walk on the treadmill if it's a day that I'm not doing my 30,000 steps, and then I lift heavy weights.
And then how many grams of protein do you eat?
A lot. I'm closer to 120 to 140.
120. I keep asking about this protein because I gotta say, I feel like every women's health blog I follow and everything on Instagram it's protein, protein. Now my algorithm is all bullying me into eating more protein, more.
Yeah.
So you eat about 100 milligrams?
120 to 140 sometimes.
Grams a day.
Yeah.
Okay.
Trying to
Okay.
build muscle more than
Right.
anything else right now.
So the lean protein, I would just say, is part of a balanced, nutritious diet.
Sure.
So we absolutely do want to push that protein, and I really try to simplify it for patients. Protein with every meal and every snack, right? If they can aim for 30 grams of protein at every meal, a chicken breast about the size of your hand is 35 grams of protein. So they can aim for 30 to 40 grams of protein every meal, and then every snack has at least 15 or 20. They're easily hitting that 100-gram mark.
That doesn't sound as daunting.
But pairing that with fiber, so that's fruits and vegetables and whole grains, and those are also an important piece of a nutritious, balanced diet. We want patients to get their fruits and vegetables as well. Again, serving at every meal would be great of one or the other. And so especially on this medication that suppresses your appetite and makes you feel fuller faster and longer, there's not a lot of space for food. So if patients are getting their 100 grams of protein and 3 to 5 servings of fruits and vegetables and maybe a whole grain thrown in there, they are not hungry for the rest of the food that's available to us, all of the ultra-processed foods.
So it kind of weeds out the junk food. There's no room for it.
Definitely.
We have some great questions and some great comments coming in. So if you have a question or a message that you'd like us to read out loud on the program, send it to us right now on YouTube or Facebook or the All Things Heart email. All the links on how you can connect with us in real time are right there on your screen. Dr. Beaver, I know you don't treat Ginger, but Ginger has had some heart complications in the past. It was 2017. So 5 years before this,
Yes.
where Dr. Farrell diagnosed you with something very scary. What was the diagnosis?
She had an anomalous right coronary artery. And so what that means is there's 2 cusps that come off, and those originate the coronary arteries. Hers came off the wrong cusp and actually comes into what we call an interarterial course, and that can be deadly and dangerous because it can get pinched, if you will, between the aorta and the pulmonary artery. Especially if someone exercises, where the increased cardiac output, where you have increase in the sizes of those vessels, and they can compress the blood vessel, and then essentially impair blood flow to the heart and almost mimic a heart attack.
So when you have a patient, let's just say you had another patient like Ginger who came to you with an already pre-existing heart complication or issue, does that change your weight management program for that patient when it comes to GLP-1s?
Yeah, I mean, I think a little bit. Every patient, we try to personalize the care, and in that particular case, there's a couple things. One is these medications do have a little bit of a diuretic effect, so the patients will lose a little extra fluid, and also as they start to lose weight, they may not require, their blood pressure will lower. So if they come to us on several different blood pressure medications, we will look closely at that, make sure that if they're getting symptomatic of low blood pressure, start to be aggressive about lowering their blood pressure medications and having them follow up with their cardiologist to continue bringing that down. And then the other thing is, in terms of physical activity, is she's a superstar, and we encourage patients to work towards that, but we want to start where they are. So I would not encourage anyone, especially someone with heart disease, to go out and immediately jump on the rower for 30 minutes. I want them to start slow and go cautiously, and really just slowly over time build up their physical activity. But we start wherever they are. So if that means a 10-minute walk once a day or twice a day, I'm all for it. That is 10 minutes of walking that they did more today than they did yesterday.
Not everybody can be Ginger and walk.
Yeah.
She's saving lives, caring for patients, walking 30,000 steps a day. Is there anything, Ginger, since you started taking the GLP-1 medication, that you've noticed, any side effects that are unpleasant to you?
No. I think I've been very fortunate in not having any side effects. I think that it's a blessing because I do hear a lot about people having side effects to it, but maybe it's because I went into this and my heart problems were mostly fixed. So going into it a little healthier than most people start, and the fact that I was already doing a lot of the things in the beginning. Like I was always walking 30,000 steps. That was always a thing. So the hardest part of that is trying to do more than 30,000.
Yeah, I would think so.
But yeah, no side effects.
And then Dr. Farrell had mentioned you were able to stop taking some of your medications. Can you tell us about the medications you don't have to take anymore? And it's because you're on the GLP-1.
Yeah.
Okay.
Yeah, I don't take any amlodipine anymore, which is a blood pressure medicine, and we're likely to probably have to take off some more of those because my blood pressure is still very, very low.
Which is great.
Yeah.
So
I think that's also why it's important to have follow-up with these, our weight reduction clinic and with people supervising it, just because that way people come in on a lot of blood pressure medicines, other types of lipid lowering that can be altered or adjusted because of success with the weight loss. So.
I want to get to some, go on.
I was just going to say that was one of my original goals for going into this field, was that I felt like I just didn't have time as a primary care doctor to address all of these different issues, and I kept adding more and more medications, and my thought was if I could treat the underlying problem, that maybe we could prevent some of those other problems or improve some of those other problems. And so it is really fun for me to see patients come off of medications.
You're getting to, is that what they talk about when they say the root cause? You're getting to the root cause of these problems. We have some great questions coming in and some great comments, so let's get to those right now. Marcia has an observation. She says, I have seen discussion that an older person's body may not be as good at using the protein eaten and may need to eat more than a younger person who can more efficiently use protein. Is this true, or is this a social media myth? So do older people need to eat even more protein than younger people?
Yes, it's 100% true.
Can you define older?
So, define older, no, I can't define older. But as we get older, we do need more protein, and actually the recommendations now for the elderly population is 1 to 2 grams per kilo. So that's now we're looking at if a patient weighs 150 pounds, we're looking at 75 to 150 grams of protein.
Okay.
So what we find in our elderly population is that, especially if they're living alone, they just kind of nibble and cheese and crackers or simple foods. And what they do need a lot more protein to promote maintaining muscle mass and maintaining bone mass. And the bone mass is really important, because if we don't maintain that bone mass, then they're at greater risk for things like hip fractures.
And that's what you don't want. That's true, because when you live alone and you're not cooking for a family or a spouse, you really do just get the nibbles. You get the cheese and crackers, and then you're like, I'm good, I have some olives. Maybe I'm just projecting, but I like how you said that. That's a good point. Jeremy has a question. Jeremy writes, I know someone taking a GLP-1 and they don't look like someone who might clinically be obese. I also associate things like bariatric surgery as something that only happens if you're pretty far along and in danger. So Jeremy's question is, what's the ideal candidate for this medication look like? Or is it a much wider umbrella?
Well, there's certainly, I think, some misuse out there, but ideally the medication is approved for patients with a BMI of 30 or greater, or a BMI of 27 or greater who have a comorbidity associated with their excess weight. And actually, for heart disease, Wegovy is now approved for patients, again, as secondary prevention. For patients who have had a heart attack or stroke, there is not a BMI qualification for that.
That was the FDA approval that we were talking about from
So for that one,
last March.
We don't so much talk about obesity as much as preventing heart disease.
So Dr. Farrell, could you have a patient that is thin but has heart problems that you would still recommend a GLP-1?
Yeah, I mean, with fitting within what the clinical outcomes trials show us, then yeah, definitely. If they qualify and have certain risk factors, and certainly for secondary prevention, then.
And would you, Dr. Beaver, have to then monitor them that they don't get underweight if they're taking an appetite suppressor medication?
So that person would probably be monitored in the cardiology clinic and not in my clinic.
Okay.
But I would absolutely monitor that person, and I would not push the dose necessarily. So what we know about heart disease and this medication is that we saw the reduction in the risk of heart attack or stroke before patients even started to lose weight. So within 6 to 12 weeks of being put on this medication, they would have a lower risk of heart disease, or heart attack or stroke. So they don't necessarily need to be pushed to the higher doses like patients with obesity who want to lose the most weight, where we see the highest weight loss at the highest dose. So monitoring that, making sure that their BMI, I would say, doesn't drop below 22, and just making sure that they're able to maintain their hydration status and their intake.
And they could still be a candidate for that. Becca has a question for Ginger. Becca wants to know if you have to take this medication long term, or if there will be a time when you stop it altogether.
I think that might be a better question for you.
Okay, okay.
Well, we don't know. I can say that in the almost 30 years that I've been a doctor, I don't know of any person that's been on one specific medication lifelong. So I do think that obesity and excess weight are a disease, and it's a metabolic disease, and we don't have a cure, we have a treatment. So what does that mean? It means that if you stop the treatment, the disease can come back. So whether it's this medication or some version of this medication, maybe at a lower dose, maybe spreading the dose out, just to help maintain weight, I do think that staying on something will help prevent regain.
And I have one more comment that I want to read. It's for you, Ginger, from Marie. Ginger writes, or Marie writes, Ginger, you're amazing. Thank you for sharing your story, and I'm so sorry for your loss. And we all are, and you are amazing.
Just doing my job.
Keep sending. Will you keep just sending us here pictures of you and Chuck, because that made our whole newsroom here in the health system happy.
Yeah.
Thank you for doing this. For today's takeaways, as we wrap up this discussion, I want to start with Ginger, because one of the things you also said was, when we first met you, you wanted to do this to honor Chuck.
Yeah.
Moving forward, what do you think Chuck would say to you right now, besides laughing at you that you're on TV?
Probably, you're so skinny. I also think that he would be cheering me on, like from the sidelines, and seeing me have so much fun with the kiddos, and just being able to watch our kids get older and live their lives. So important for all of us.
And you're doing all the things.
Yes, all of them.
Thank you for sharing your journey.
You're welcome.
Dr. Beaver, what do you want our viewers to know?
Well, I would say that understanding how the medication works so that you can work with the medication is going to give you the most success. And also thinking about quality of life. It's not about a number. It's about quality of life. It's about chasing those kids and feeling like you can do things that you weren't able to do a year or two ago. So we're really excited about improving patients' health here.
Dr. Farrell, as we wrap this up, what do you want your heart patients to know?
Be an advocate for yourself. I mean, explore the information, have this conversation with your doctor, get to know your risk factors, do what you can to boost your IQ with regards to your cardiovascular risk. And I think for clinicians, it's follow the data. The clinical trials are going to continue to expand, so there's probably going to be even more and more indications for this, especially now that we have oral availability of these, not just injectable. So stay tuned.
Stay tuned. Lots happening in the science world. Thank you so much for giving us your time today. And Ginger, thanks again for sharing your journey. You're going to help a lot of people. And thank you to our viewers for joining the conversation. If you'd like to watch or share any one of our past episodes, just scan the QR code that's on your screen right now. That will take you to links of all of our past episodes. And we'll see you right back here tomorrow morning.
Coming up tomorrow on the Morning Medical Update, getting answers for your lung health just got easier. I'm Jessica Lovell. On the next Morning Medical Update, we show you the program that revamps navigating the lungs, providing a more precise way to treat and diagnose lung conditions. Friday at 8.